next speaker is Barbara McCann. Barbara's PhD and is a professor of psychiatry and behavioral sciences, mental health counseling, and hypnosis endowed chair at the University of Washington in Seattle. Her clinical psychology practice is based at Harborview Medical Center, where she treats individuals with depression, anxiety, functional seizure disorder, and insomnia. Dr. McCann teaches and supervises psychiatry residents, psychology residents, medical students, and fellows, and has received numerous teaching awards. She is a proud Husky, having worked for UW for nearly 40 years. Please welcome Dr. McCann.
Okay, great, thank you. What do I push? Kevin? I don't see a keyboard, so I'm not sure what I push to get it up. Is it a touchscreen or? Oh, okay, great. Thank you.
You're right there, right?
Okay, got it.
Okay.
Thanks. Okay, I'm gonna just.
There it is.
Okay. Excellent. All righty. So I'm presenting today on functional seizure disorders for this conference, and this will seem a little bit like bringing a cabbage to a flower show because you're here to hear about epilepsy, but I'm going to hopefully convince you that this is something that's really important to think about, and I'm really grateful that I had the opportunity to hear Dr. Morgan earlier because I'll reference some of what she was bringing to your attention as well. I have no relevant conflicts of interest to disclose. As a psychologist, I might disclose other things but about myself, but I do not have any conflicts of interest. So let's talk about what functional seizure disorder is. You might know this topic, this condition, by other names. You might have heard of it as a non-epileptic seizure or attack, as conversion disorder, a dissociative seizure, pseudo-seizure, and psychogenic non-epileptic seizure, PNES. So it's gone by a lot of names over literally about 150 years, maybe 160 if we think about when Charcot was at his prime as a neurologist looking at this. But currently the preferred terminology is functional seizure disorder or functional/dissociative seizure disorder. And we'll get into a little bit about why that's the case as we go along here. So a seizure is a sudden and involuntary change in behavior, movement, sensation, and or alertness. It's usually brief, but as you saw from the previous discussion, not necessarily, and very concerning when it is not brief. And epileptic seizures and functional seizures are very different from one another. In an epileptic seizure, you have something going on in the brain that's associated with abnormal activity on the EEG during the actual event. And in a functional seizure, there's no EEG correlate. So you see an event without there being any kind of change in the EEG that would indicate or explain why something's happening, why that event is happening, that looks, for all intents and purposes, like an epileptic seizure. There are different ways that you can distinguish these two types of seizures. One's based on the EEG, obviously, but it's hard to capture this kind of seizure on an EEG unless it happens while the person's getting an EEG in a neurologist clinic or other setting. You can have an ambulatory EEG where you have people wear a home monitor for several days and indicate if they've had an event. And if they've had an event, but it's not accompanied by electrical activity that's abnormal, then you have pretty good evidence that what's going on is not epilepsy. It's more likely to be a functional seizure. Another common method of looking at this is, of course, the long-term monitoring unit, epilepsy monitoring unit in a setting such as at Harborview where I work. And during a stay on the epilepsy monitoring unit, what's trying to be done is seizure characterization, understanding what's underlying the seizure. And in that setting, you may see a functional seizure, an event that the patient identifies as a seizure that looks like a seizure, but there's no abnormal electrical activity on the EEG. And lastly, and importantly, a trained neurologist can often determine whether or not a seizure is functional by the semiology, and what that means is what it looks like. Now, the interesting thing is the Regional Epilepsy Center at Harborview has given me the opportunity to sit with them for many, many months as they evaluate cases and as we look at video EEG monitoring. And much to my surprise, it's sometimes hard to tell, even with video EEG monitoring, when you have the event before you and you have the EEG simultaneously. It's not always easy to tell. And so that's why I think it's really important to think about all of these as coming together to give us some idea of what's going on in the brain for the individual that's having this experience. Now, why even talk about this at a conference on epilepsy? So just some things that I want you to have as take-home points. Between 5 to 22% of people who have functional seizures also have epilepsy. So you can have both types. And between 5 and 20% of outpatients with epilepsy can have functional seizures. So now you know why I'm bringing this to this particular group, that 5 to 20% of people with epilepsy can also have functional seizures. Functional seizures also occur in people who've had epilepsy in the past, such as when they were children, and it may have resolved. They may have gotten to a point where they no longer need to be on anti-epileptic medications, but they can develop later on. And basically, having a diagnosis of epilepsy in the past or currently increases the likelihood of having functional seizures. You can see functional seizures anywhere from childhood on up to age 90 and beyond. They affect quite a few people, but there are some important distinguishing things that might give us clues, and I'll get about why this happens, and I'll get to those in a moment. Now, it's important to accurately diagnose functional seizures for a lot of different reasons. One is various medications, anti-epileptic drugs, VNS. These things aren't helpful in treating functional seizures. And often it's the case that someone will come to the attention of a neurologist, already be taking anti-epileptic medications for seizures because they were administered by another neurologist or initially in an emergency setting. And it turns out the patient has been taking medications they don't actually need, that are not actually helpful, because the seizures aren't epilepsy, they're functional. Now, it's important to note that some of those medications that they're taking can help with certain emotional conditions that might underlie the functional seizures. So you see how the picture gets very complicated quickly. So it's important to have those kinds of discussions and really evaluate some of the medications and see if they're helping with other kinds of co-occurring conditions. So for example, as a psychologist working in a psychiatry department, I know that for many, many years and currently, the medications that are given for seizures are often used to treat depression and bipolar disorder. And so it's really important to evaluate what role a medication might be having for someone who, it turns out, has a functional seizure disorder. It's also the case, and this is where I really want to reference Dr. Morgan's talk, that functional seizures, one of the things that differs them from epileptic seizures is that they often last longer than an epileptic seizure. Typically, although as you saw from Dr. Morgan's talk, they're relatively brief. Epileptic seizures, functional ones last much longer, but it gets very complicated, because what that means is someone can end up presenting to the emergency room with the assumption that it's status epilepticus. And so you start to see how that could lead to unnecessary treatments for someone with functional disorder who's seen in an emergency room. And then the other thing to think about is that fear and anxiety about uncontrolled seizures of any type, fear and anxiety about uncontrolled neurological disorders of any type, or about one's medical conditions of any type, can lead to more functional seizures. So it gets even more difficult to tease out some of what's going on. Next point, I think, is in many ways one of the most important points I want to make today, and that is that people with functional seizure disorder are suffering. They suffer. They suffer a great deal. And it's really important to think about that as caring individuals, that they suffer, and the suffering is very real. There are some consequences of functional seizure disorder, some of which are shared with epileptic seizure disorder. And again, remember, 5 to 20% of people with epilepsy may experience functional seizures. So some of the consequences include the fact that in functional seizure disorder, the seizures are much more frequently occurring, sometimes, multiple times a day, too many times a day to even count, okay? The seizures are disturbing and disruptive, embarrassing. It can lead to inappropriate medical treatment that's unnecessary. These patients experience a great deal of frustration and guilt and shame about having functional seizure disorder. They may miss work or school, just like someone with epilepsy may encounter that. There's social isolation, because people are concerned about having these events frequently around other people. And there's a considerable amount of stigma, both within the general community and also in the medical community. So I think it's really important that you think about this in terms of people with functional seizure disorder are suffering. They're not faking it. Now, this is a really important distinction, another really important take-home point. From a psychologist or psychiatrist perspective, there are situations in which we see people faking medical conditions of many different types. And those are something called factitious disorder, in which it appears that the person is faking a medical condition to get attention, and they tend to like going from city to city to city and appearing in emergency rooms to get attention. So that's one kind of condition. A factitious disorder is faking it. You might know that disorder by the other term, Munchausen's syndrome, okay, or Munchausen's. And then the other stigma that can happen, or coming back to other conditions where you see that, we also see faking it in malingering. So if you have someone who is presenting to the emergency room, I just had a seizure, I think I'm about to have another one, One of the things the emergency room doc may be thinking to themselves is, are you doing this to get benzodiazepines? Benzodiazepines are a drug of abuse. And so it's common to be concerned about whether or not someone presenting with something without an EEG correlate is just malingering or has factitious disorder. But there are a huge number of people around the world, regardless of country, regardless of culture, who experience functional seizure disorder. Patients themselves really struggle with loved ones saying, well, this is all in your head, since they can't find a cause, since the medical community has not yet identified a footprint for this kind of seizure in the way we have a footprint for epilepsy, the EEG. And so patients are often told it's all in your head. Patients come to me believing it's all in their head, and so they're experiencing a great deal of shame when I see them. And I have to help them see that it is in your head, but it's not all in your head in the way that you're using that term. And I'll talk about that and how I communicate that to people in a way that is respectful and also humble, because we don't really know exactly what's going on. There are a lot of clues, but we don't know exactly what it is. So, what causes it? Now, there are some clues, and these are also important things to think about. And if anyone wants these slides, please see me afterwards, and I'll email them to you, okay? But there are some clues. 70% of people with functional seizure disorder are girls or women. Now, if you think back to the time of Charcot, when it was still that situation that what he was referring to as either hysteria or conversion disorder, women were treated differently than they are now, and the notion of female fragility was really strong. And so it could have had a social implication. But there are other factors to consider that are things that are related to being a girl or woman in the world, and that includes higher incidence of traumatic things happening, some depending on the society, of varying degrees of suppression of rights that we see sometimes. There are a lot of stresses that go with women, and women experience dramatic hormonal changes throughout their life that are really important to consider as well. So there are a lot of possible reasons that this could be more fully represented or seen more often in women. The common presentation of functional seizure disorder is a woman in her late teens or 20s. That's a time when people present with this. But we also see functional seizure disorder turning up in the perinatal period or after childbirth. So that's a common presentation as well. All of these are clues, help us figure out what's going on. Also help us determine or realize that we may be dealing with something that has different presentations and a little bit different causes depending on who you're evaluating. So that means, of course, greater heterogeneity, that there's a bunch of different people in this category potentially. So we know that people with functional seizure disorder on average have higher prevalence of abuse, trauma, and life stress in childhood. And of course, especially in childhood, and of course I'm referring now to the population I treat, which are adults with functional seizure disorder. The picture will look a little bit different with children and adolescents with functional seizure disorder. Of course, they're still children and adolescents, so we have to think about things a little bit differently in that group. And people with functional seizure disorder have higher rates of depression, anxiety, other kinds of psychiatric conditions. And again, the thing to think about here is, are we seeing a result of functional seizure disorder, or are we seeing something that's potentially contributing to it? So, what's going on in the brain of someone with functional seizure disorder? The best we can understand it is that it's a disruption in the functioning of neural networks. What do I mean by neural networks? Now, this is actually something we have increasing amounts of evidence that functional neurological disorders overall can be attributed to some disruption in the way the neural networks are communicating with each other. And one way to think about it is that epileptic seizures are a hardware problem and functional seizures are a software problem. I was thinking about this as I was repeatedly yesterday at work getting the program not responding message on my computer and having to shut things down and start over. It's a little bit like that, program not responding. Usual way of handling stress and disruption and other kinds of factors, program just not responding the way it should. The other analogy that I often use with people is, let's think about how many of you have ever ridden a bicycle as a child. Many of you have, right? Okay. And you know that if you can get on a bicycle now, you probably can get the hang of it quite quickly, much more quickly than when you first learned it. I think bicycle riding is an excellent example of a neural network because many different parts of the brain are involved. And when you get on the bicycle, all those different parts that can include the vestibular system for balance, the motor cortex, sensory motor cortex for taking information in so that you can respond and so that you can continue to pedal and change the rate at which you're doing that. You know, the visual cortex is involved. Many different systems are involved. And how is it that we cannot do that at all for 25 or 30 years and get back on a bicycle and it comes right back to us just like that? That's an example of a neural network. So we have all sorts of neural networks. Any kind of rote little program that you in particular can do, whether it's sitting down to a piano after a long time, being a little rusty and picking it up again really quickly, that's an example of a neural network. So our best understanding then is that in functional neurological disorder, there is a disruption in neural network. I need to keep an eye on the time. Okay, I'm doing all right. That's good. So it's a neural network. And one of the reasons that you're hearing about functional neurological disorder, of which functional seizure disorder is a subtype, is over the past 10 or 20 years, there have been considerable advances in being able to do brain imaging under a lot of different conditions. And that's allowed researchers to discover things that might be activated during a functional seizure and to start to generate some hypotheses about where some of these networks are and how they're communicating or how they get disrupted. So what about treatment? So here's an interesting thing about functional neurological disorder, and I want to really say hats off to the epileptologists at Harborview Medical Center because they treat many potential patients that could come my way because they do such a good job of communicating the diagnosis of a functional seizure disorder either in addition to or instead of epilepsy when they talk with patients who've been in the long-term monitoring unit. So it's not uncommon that they'll refer someone to me because they agree to do that, but they've delivered the diagnosis in a really clear, compassionate, unambiguous manner. And some degree of patients will only need that to get considerably better. And if you think about it, what the patient's learning is, first and foremost, you don't have epilepsy. They're finding out, they have something in addition to epilepsy, of course, in that 5 to 20% that I mentioned earlier. The other thing they're finding out is you don't need to take those medications you've been taking. And so as patients start to learn a little bit more about what's going on and reflect, they seem to do, at least a small percentage of them, a really good, I wouldn't say small, a significant percentage of them can take that information and process it and use it and reduce or eliminate having functional seizure episodes. So I end up seeing that a lot. I'll get someone that I'm seeing, they had been having seizures daily before they go in for the video EEG monitoring. The epileptologist does a really nice job of conveying what's going on. By the time they see me, we're doing the work of treating them using psychological methods, but they're already treated. And we're just kind of putting the icing on the cake there. So that's one interesting aspect about it. There are various forms of psychotherapy that help to reduce seizure frequency and intensity, and improve other aspects of life. There's a lot of research on health quality of life in epilepsy and in functional neurological disorders. And so that can be really helpful, and I'll talk a little bit more about what happens in some of those psychotherapies if you'd like. But these treatments have been found to not only change the nature of the seizures in terms of intensity and frequency, severity and that sort of thing, they change how people respond to them. So they're likely to make far fewer emergency department visits. It improves depression, it improves anxiety, it improves other things that they've been struggling with, and gives them tools for dealing with life stress in a different way. Who doesn't want that? Because life stress isn't going to go away. It's just there. It's one of the conditions of being alive, right? Having a seizure action plan is actually helpful, very valuable for people with functional neurological disorder, and especially functional seizure disorder, because it helps the emergency medical service know, first of all, that this patient knows that it's not epilepsy. And it also can help guide treatment. But especially in rural communities, in isolated communities, and I'm glad that was brought up, that gets really tricky because the EMS that are responding are often the same 6 or 7 people that have seen this before. And a lot of the shame that comes with having a functional seizure disorder comes from how the medical community responds to it. Remember, emergency departments are about preventing serious loss of function and about preventing loss of life. And a functional event is not going to be associated with loss of life. And emergency rooms are very busy places with not much time. And so it can be frustrating and lead to burnout when physicians and others and other personnel are seeing patients over and over again for whom they can't help, really. So having a seizure action plan can be really helpful. Case in point, we've developed that for a certain number of patients that I've seen in conjunction with the neurologists that they're working with. And once they had the seizure action plan, those emergency visits stopped. That can be really significant. So those are really important for functional neurological disorders, and especially functional seizure disorder, and something for those of you in school settings to really think about. I can talk with you about some resources for where you can find examples of action plans for functional disorders that you can implement in school settings. The other thing is to understand that there are more general treatments for functional neurological disorder, functional tremors, functional gait disturbances, functional sensory disturbances, functional cognitive disturbances. There are many. Anything that a neurologist sees, pretty much, can also be attributed to functional causes in some cases. And in outpatient neurology settings, the number of patients presenting with functional problems can be from 20 to 30%. It's quite a significant number. That's general outpatient settings for neurology. So, just to summarize, functional seizure disorder, number one, is real and it's associated with suffering. Some people with epilepsy, 5 to 20% is our best estimate. There's a lot of variation from study to study, but generally speaking, 5 to 20% of people with epilepsy will also have functional seizures. And it's a brain network problem, not an anatomical problem. It's a different kind of problem, the kind of problem that I think neuroscience is only beginning to get a good grasp on. And lastly, there are many ways to help, many ways to support people who have functional seizure disorders. So I thank you for your time, and I'd be happy to take questions. There's a question here, and you'll need to use the mic so that I can hear you and everyone else can, okay?
So I noticed that you said 70% of people with PNES are girls/women. Have there kind of been noticed? Has anyone noticed like a correlation between uterine problems such as endometriosis, PCOS, etc., or has that not been studied very much?
That's a great question. There is some, obviously in these large cohorts of people with functional seizure disorder, and there are several, things like that are looked at. And what I will say is generally there's a higher percentage of any kind of other health problem. Some of those are also other functional disorders like functional GI disorder, which is, definitely a gut-brain connection, and things like that. POTS is another common one, making a distinction between POTS and a functional seizure disorder, and epilepsy is very important, and we see a lot of that. So there are a lot of different things that can happen. I don't know specifically about endometriosis and those sorts of things you mentioned, but in general, that's the finding from the research. I have a question here.
Thank you. So sort of as a follow-up to that question, I was curious whether the incidence, the frequency changes during perimenopausal, postmenopausal women, and if there's a change.
I don't think we have good data on that just yet. I certainly see people who develop this problem later in life around that age. Whether it's specifically linked to that is hard to tell. But some people will certainly maintain that it seems to be related to being in the perimenopausal phase for them. They feel like if they can control their menopausal symptoms, they'll do better. The same thing could be said for some people who experience things like premenstrual dysphoria or difficulty related to menses. So good questions, and we need a lot more data. Women don't tend to get studied very much. This is part of the problem. Yeah.
Thank you, Dr. McCann, for an interesting and very important talk, in my opinion, because there is actually much more overlap, I feel like, than we might mention in the community. But I had two questions, and you don't have to get too much into the weeds, but talking about different forms of psychotherapy to address these. I know that I commonly talk about cognitive behavioral therapy.
Wolfgang, because of my hearing issue, I'm having a little trouble understanding what you're saying. So
okay. Let me speak up. Is it better now?
Probably slower and louder will work for my aging ears.
No worries. Is it better now?
Yeah.
I'm happy to project a little bit more. So two questions. One was pertaining to treatment. As I mentioned, I commonly talk about cognitive behavioral therapy, or CBT, in that context. So if you could briefly maybe see like what's the background there, and how does that relate to the network that we're trying to alter, trying to reprogram the brain, right? Trying to update the software, so to speak. And then the other question I had was, how important is it to not just, educate the patient, but their caregivers, their environment about this, because that might actually impact how people react and how people feel about the condition as well.
Yeah, so just to give you an idea of treatments, of course, when Charcot and Freud were looking at this, treatments were very different back then than they are now, and some of the treatment, or at least the study of this, was through the use of hypnosis. And if you were paying attention to my credentials there, you may have heard that word. So that was, latter part of the 19th century, early part of the 20th century. Then Freud predominated, so we saw psychodynamic, psychoanalytic approaches. Long about the time I hit graduate school, cognitive behavior therapy was the rage. I've only been raised as a cognitive behavior therapist. I don't get psychoanalysis very well, and when I tend to see it from a CBT lens, right? So that said, CBT is immensely popular and well-researched, and the two programs that I'm most familiar with, actually all of the programs for functional neurological disorders more generally that I'm most familiar with are cognitive behavior therapy based, either all or largely based in that way. So for example, one of the real pioneers in treating functional seizure disorders and studying it more broadly is Dr. Kurt LaFrance. He's at Brown University, I believe, in Boston. No, Rhode Island. I misspoke. Sorry, Kurt. I was just on a conference call with him yesterday. I feel bad about that. He's a very incredibly compassionate man who is so dedicated to the work that he does in functional neurological disorders, especially seizure disorders. And the program that he put together and published in 2015 is based on a 1989 program that Joel Ryder and others put together for epilepsy, for people with epilepsy. And it's a program that's built around the idea of getting adequate social support, letting others know what's going on, being able to analyze precursors to a seizure. So for example, recognizing when an aura is coming on and being able to get yourself in a safe setting, for example, so you don't have injury, but even being able to, in some instances, not always, do some things personally to bring your stress level down so that you can possibly avert a seizure, but certainly increasing and improving the quality of life for people with epileptic seizures. So Kurt paired with Joel Ryder and Donna Andrews, the other person involved in that work, Donna being someone with epilepsy, and they put together a treatment manual, treatment program for functional seizure disorder that's also used, by the way, with people with both. And so I see people with both kinds of seizures, functional and epileptic. And what it goes through is, I can rattle off all the chapters by heart by now, but what it goes through is helping people decide if they're ready to start treatment, because there's a big commitment. It's a lot of work. The patient does a lot of work between sessions. Think about their social supports, and along with that, think about how they communicate a need for support to others so that they're doing it in the most optimal fashion that they can. Understanding about their particular drug therapy, and this is important for everybody. Then identifying triggers. What are my triggers for a seizure? Either epileptic, non-epileptic, or both. Learning various ways to respond to triggers. Recognizing your pre-seizure aura, important for both kinds. Learning how to reduce external stressors, learning how to reduce internal conflicts, learning some basic relaxation strategies. I mean, who upon hearing that just wants to sign up for a program like that? Because I think it's really important. Very early on in my career, I just taught some general group stress reduction things for people in work settings because it was really important. So that's a lot of what's done. So Kurt LaFrance and colleagues have produced a randomized controlled trial, multi-center, with good results. There's also a group in the UK. UK, by the way, seems to be far ahead of us in understanding and addressing functional neurological disorders more generally. And the UK program conducted by Laura Goldstein is called the CODES trial, which stands for something, something, something. I'm sorry, I don't remember what it is. That wasn't very helpful. CODES trial, C-O-D-E-S. If you put it in your favorite search engine, CODES trial and seizures, you'll find it. And that one also is very cognitive behaviorally based, and so I've used both with patients. It just so happens that you can get access to the CODES trial materials by writing to Laura Goldstein and being very upfront about how you're going to use the materials, in terms of how you intend to use them. Can't use them to publish your own book, for example. I probably, you get me started, I'll keep going. And let's take another question.
Thank you again. So given that it is thought to be a network problem, and given that people with functional seizures can have epilepsy and people with epilepsy can have functional seizures, what is the data, or is there any data on sort of the frequency or in a person who might have controlled epilepsy versus someone, and seizure-free, but someone who is, highly drug-resistant or refractory?
Yeah, to my knowledge, that hasn't been looked at. If anyone else knows of a study that has addressed that, I'd be very curious. But to my knowledge, that hasn't been addressed. Just to give you an idea, I want to make sure I'm not taking up too much time, but we're good. Just to give you an idea of the pace at which this field has grown. Kurt LaFrance is the author of a textbook for physicians and other researchers on non-epileptic seizures, basically. And he's been doing this work for a very long time, decades. And there's an earlier edition of that book. The most recent edition was published, I want to say, around 2017 or so. But an earlier edition of that book, they showed the first meeting of the functional, I think they were calling it the Functional Neurological Disorder Society then. It was a room of about 12 people. So this was back in the aughts of this century, I believe. Not this past June, but the one before that, I went to the conference, and there were 500 people there. And 2 years prior to that, there were only 100 people there. So it has really grown exponentially in terms of interest, and what that means is research in this area. Yeah.
Thank you for your discussion. I come from the Dravet Syndrome Foundation, both as a founder of the Dravet Syndrome Foundation and also a parent.
I'm sorry. Again, because of my hearing disorder,
Okay.
I'm having a hard time.
Test. How's that?
We'll try it.
We'll try. Okay. Just to repeat, I come from the Dravet Syndrome Foundation as an advocate and also a parent. And my question goes to, with a disease as complicated as Dravet syndrome, when would...
I'm sorry. Do you mind coming up here? I'm so sorry.
That's okay. Can you hear me?
I can hear you.
I think it's the echo.
Yeah.
Okay. I'll speak so other people can hear. I come from the Dravet Syndrome Foundation and also as a parent. And in the adult population, what we are discovering are the changes as our children turn into adults. This is not a conversation that has ever been discussed in the Dravet world. And it is something that parents are definitely talking about as our children's seizures manifest in different lights. So 2 things. First of all, when should this discussion occur between neurologists and families, especially if we are hypothesizing that something like this is an addition? The other is it's so easy to lump this in with one of the comorbidities of something as severe as Dravet syndrome. So I'm curious from your perspective, not being a neurologist, how you would start that conversation